I'm gonna, for a hot moment, take my mask off since I'm gonna be, 6 feet away from everybody because I hate it when people are talking and they got their mask on and nobody can see them. So I want to thank everybody for taking time out of their busy schedule to come. I know it's unusual circumstances, but I think it's going to be a really great, informative night. We are very fortunate to have both Cam Ayala, who is not only a lymphedema patient, but he is also a representative, and he has extensive experience with the Optimal Plus, which this pump is the most programmable pump on the market. We're very excited to show you all the benefits and features of this pump, because it's just a fantastic pump. And we also have Dr. Chen, who is sharing all of his wealth of knowledge with us and all of his groundbreaking interventions, surgical interventions, which is just very exciting to see the new treatments that are coming along to help these patients. So without further ado, Cam is going to get started. Thank you.
All right. So I'm going to start off with a little video because everyone likes a video. Okay.
Oftentimes I'm telling people who've never heard of lymphedema, have you ever rolled or sprained your ankle playing sports or just walking around? When that happens, when that trauma happens to your ankle swells up. That tight, deep, sharp shooting pain, that's your lymphatic fluid. So having lymphedema essentially means you have a compromised lymphatic system, whether it's in your arms or your legs, and it's chronic. You're gonna have to deal with it with the rest of your life. So deep pain on a daily basis. There's the aesthetic part where you're going to have a swollen limb, whether it's your arm or your leg, so people may tease you for looking disfigured. That was very difficult being diagnosed with lymphedema because naturally a lot of people think lymphedema is lymphoma. They sound similar, but they're very different. When you're a little child, 11 years old to be exact, and a doctor tells you you may have cancer, I was honestly scared to even ride my bike or do anything that any normal 11-year-old child should be doing. And it was very frustrating because I had several physical therapists tell me, oh, Cam, your leg's just getting stronger. That's the muscle tissue building. But it didn't feel like I was getting stronger. It felt like I was getting weaker. My body constantly ached. I struggled with walking up and down the block. Anytime I put any type of weight on my right leg, it felt like my bone was about to collapse in itself. The Lympha Press is a pneumatic compression device. Essentially, it's home therapy for any patient that deals with lymphedema or any chronic swelling where they need relief, to get that lymphatic fluid moving, to break down the volume, and to really have a quality life once again, to do basic things like walk up and down the block, to be able to attend a concert, to be able to go to a wedding, to be able to live a normal life. And that's what the Lympha Press compression pump has given me. It's given me that quality of life back. Lymphedema is not a death sentence. It is a sentence to live a new life. You can go on a reality TV show. You can speak at conferences. You can ride your bike again. You can dance, even if you're a bad dancer like me. There are no limits to the things that you set your mind to. And I've finally felt that with Lympha Press.
So, okay, let me close all this stuff up because they've literally put like bachelorette stuff in any videos that I post. So it's like I'm forever cookied to that kind of content.
Those emotions, they were put on hold by time, by careers being built. But at Claire's Bridal Week.
Okay, thank you, Claire's Bridal. Okay. All right, so as the video just said, so I'm Cam, and I live in Houston, Texas. So I'm not used to this cold weather at all. This is probably the coldest I've been in many, many years. So happy to be here. A lot different than visiting Dr. Chen and Deb in the summertime, getting to go out on the boat and all that good stuff. But I'm here for a couple of reasons. One, to share a little bit about my personal lymphedema journey. And the next part, I'll be talking a little bit more in depth about the Optimal Plus from Lympha Press. And then I have the esteemed privilege of introducing our next speaker, Dr. Chen. It's interesting watching that video that I just played back now. Things like concerts and weddings, things that we took for granted. That was obviously filmed way before COVID. And when I was little and I was told that I have a disease that there's no cure for, we now know that that may be a thing of the past. Not for every patient, obviously, but I'll let Dr. Chen go in more depth with that when it's his time to speak. So I'm just going to give you guys a high level, like 10,000 foot overview of my medical journey as a lymphedema patient and where I'm at today, and then ultimately how Lympha Press specifically has played a pivotal role in my management of my lymphedema. So when I was about 11 years old, growing up in Houston, I was playing just regular basketball, YMCA league, not super competitive. But as I was running up and down the basketball court, some of the coaches and the parents were saying, hey, is Cam okay? It looks like he's kind of limping up and down the court. And I just remember at that age having a lot of lower back pain, and I figured it was just your standard growth spurts that's pretty common with that age. And I went to an orthopedic doctor in Houston, Texas, in the medical center, and they identified very quickly from some initial x-ray imaging that my right leg was actually about 1.5 inches shorter than my left, and there was some interesting spotting on my right distal femur that was showing up in the x-rays. So initially the doctor said, well, I want to make sure this isn't cancer, so let's go ahead and do a bone biopsy surgery. And kind of as the video alluded to, if you can imagine yourself at 11 years old, or if you have kids or spouses or you know, anyone else in your age, at that age group at age 11, and to be told the C word cancer, it was pretty traumatizing. And obviously my parents wanting to do what was in my best interest, they said, all right, well, let's do this bone biopsy. So they did the bone biopsy, and fortunately it was benign, it wasn't cancerous. It turns out it was just a hemangioma on the right distal femur, so nothing too alarming. But about 2.5 weeks after that initial bone biopsy, I started to develop really bad swelling in my right leg. Not so much below the knee, but basically like the knee all the way up to the hip. And it was progressively getting bigger and bigger and bigger to the point where I want to say about 1.5 months post-op, it was about 3 times the size of my left leg. And I can't even recall how many specialists I went to. And bear in mind, this was in Houston, Texas, right? And this is the medical center. So MD Anderson, Methodist, Memorial Hermann, some very top reputable facilities. And it took me going to the Shriners Children's Hospital to see a geneticist who did some genetic testing and said, you know, I think you may have a condition called primary lymphedema. And this was way before the days of Google image search, or really the internet was still in its infancy, so I didn't really have much research to go off of other than the little trifold that they handed me at the clinic, which I'm sure you guys have all seen that at some point in time, the lymphedema 101 type of thing, where you see elephantitis and you see these really extreme cases. And I was told by these physicians that, yeah, there's no cure for this disease and you're gonna have to deal with it for the rest of your life. So I was doing an interview recently, a podcast interview, and looking back on it now, I think that was the moment that at age 11 I became a man. And I know there's different rites of passages of what makes a man or a woman, but in that point when I was told that you have a progressive condition that there's no cure for and it will get worse if you don't do anything about it, that's kind of what I guess scared me into compliance at the time. So I was fortunate enough to then be transferred to a wound care clinic that actually had a couple of lymphedema therapists there. And that's more of a rarity. I don't know here in Ohio, but definitely in Texas, we don't see a whole lot of lymphedema therapists actually in a wound care clinic, which still blows my mind because I think the two are so interrelated, right? Because most patients with lymphedema at some point or another will develop some sort of chronic wound. Not every patient, but especially lower extremity like I had. And once I finally met with my first lymphedema therapist, she, got me on the wraps and eventually compression garments, nighttime garments. And I tried a pump and it was okay. But we're now gonna fast forward from that age 11 diagnosis to when I was about 24 years old. And this is where, if you saw in the video, a lot of scarring and surgical procedures. So basically in 2014, 2014 is when I started to experience severe infection. And initially I thought it was just cellulitis, because that's obviously relatively common with lymphedema patients. But turns out now that we think that it's been osteomyelitis this whole time. So from 2014 till 2020, I've had now 8 episodes of infection. And that have all required pretty, in-depth debridements of cleaning out the leg and PICC line IVs, all that stuff. So, but I want to rewind to 2016, because in 2016, after a bout of infection, I hadn't been using a pneumatic compression device in many, many years. And so I had a physician in Austin, Texas, where I was living at the time, prescribed to me another device, which I will not name names, but it required a Velcro apparatus that I would have to Velcro at the very bottom and then ultimately up in the core region, because after getting lymphoscintigraphies and lymphangiograms, and before my first IC green in Houston, they identified that there appears to be more of an issue in the trunk region that we needed to compress. So after using that other device literally about 2 or 3 times, and bear in mind I was 26, I'm 6'4", I was pretty slender and healthy, I could not figure out how to put it on. And I watched a YouTube video that was on that one particular garment. It was a 10-minute long video, how to don and doff the garment. And I got to the point where I was so frustrated, I literally threw it underneath my bed, and it never saw the light of day after that. And I was fortunate because I started a brand new job about 2 months later, which meant a new insurance policy, which then I reached out to one of my lymphedema therapists on the West Coast, who said, well, Cam, you need something that's gonna provide you with adequate trunk compression. Have you thought of Lympha Press? And I'd never heard of Lympha Press at that point in time. So when I went online and saw the pictures, I'm like, okay, it's literally just 2 zippers that I had to put up to put on the garment. I think I can manage that a little bit better. So I did that, and really that was what kind of led me down this whole new path of compliance, because I think that's one of the biggest challenges you as therapists or physicians may face with lymphedema is compliance. And in my opinion, I think compliance is binary, right? There's not really a lot of gray area, because you either are or you are not. And I tell all the patients that I see in the Houston area, because one of the most common questions I get about specifically the Lympha Press, how often do I use this thing? Am I gonna have to use this for the rest of my life? And I'll let him go into the surgical intervention later. But my kind of canned response is, well, you should really treat your lymphatic health like your dental hygiene, in that you should brush and floss every single day. And when it pertains to your lymphedema and gravity don't take any days off. So you almost kind of got to view it in like risk-reward analysis. If I don't wear my compression garments, if I don't see my lymphedema therapist, if I'm not practicing self-MLD, if I'm not using the pump, what's going to happen, right? And I know it differs from patient to patient depending upon their severity and other pre-existing conditions, but for me, living a very busy, young, active lifestyle, I knew that my pump was always going to be my bookend for the evening, right? So I would wear my compression garments in the daytime, and then I would wear my pump in the evening time, and then I would follow it up with a nighttime garment. So I like to tell patients it's kind of a compression ecosystem. I think it's very important to level set expectations that a pump is not going to cure you of lymphedema, right? It's another tool in the toolkit. The pump does not replace your lymphedema therapist, right? Because you guys add so much value to their treatment, giving them education and really just kind of talk therapy too, right? I know for me, I've enjoyed having more in-depth conversations with my lymphedema therapist than my actual therapist. So there's definitely that value you guys add too. So now I'm going to segue into the Optimal Plus. I've been personally using the Optimal Plus for a little over 1.5 years now, since I started with Medical Solutions. And one of many things that I really like about it, other than the ease of donning and doffing the garments, is what Deb was talking about earlier, is the level of programmability. So I'm now going to demonstrate really quickly utilizing the Lympha Press app, which is free for patients. It's compatible with Apple and Android devices. I have obviously an Apple iPad here. And basically what I'm going to do is use the free Lympha Press app to sync this iPad to one of those demo pumps back there and just go over a couple of the features and functions. And when we were coming up with the name Lympha Press Optimal Plus, the plus in it is really you guys as the therapist, because this is actually the only pneumatic compression device that allows you guys and gals the ability to really collaborate with your patients when it pertains to their pneumatic compression home therapy, right? Most other pumps, they'll get it pre-programmed from the manufacturer. Maybe you have an upper extremity patient where you say, okay, I want Mrs. Smith to have 30 millimeters of mercury, and that's the pressure setting that she gets, and it doesn't give her the ability to change that. Or maybe you have a lower extremity patient who has a lot of fibrotic tissue who you want to have more pressure, maybe 60, 65, whatever the case may be. With the Optimal Plus, it gives you that ability. I like to say it keeps you in charge even after you discharge, right? So using the free Lympha Press app, you can literally create customizable treatment options for your patients that you can send to them via text message or via email, right? So I'm going to show you really quickly just a way to do that. So that back demo pump there, right where Deb is, I know it's kind of blurry, but essentially right here you can kind of see it. So using either your smartphone or your smart device, it's just like, so it uses Bluetooth technology. So it's basically just like carrying your Apple Watch or your AirPods or, you know, Bluetooth speakers like that. So I'm now going to connect to Jake's demo pump back there. So just by tapping that. And now we can go through and start getting a little bit more customizable. So even starting here at the time, so right now it's set for 40. So if this patient wanted to do, you know, say an hour, for example, you can just toggle it to 60. Hit OK. And then now thinking about the pressure, let's just say this is a lower extremity patient. We'll call her or him bilateral, so both legs. And we typically will start them out at 40, but let's just say for this patient, there's a lot of fibrotic tissue, so let's go, we'll call it just 50 for the sake of the demonstration. Another very unique attribute about the Lympha Press Optimal Plus is the ability to give the patients 2 different compression modes, right? So another leading lymphedema pump manufacturer, again, we'll name nameless, only utilizes what's called like a wave-like compression where it inflates, deflates one cell at a time. Whereas with the Optimal Plus, we actually give the patients 2 different compression modes, right? So they can do sequential, which again, if we're talking of the example of a lower extremity, it will inflate at the bottom from distal to proximal, maintaining that distal inflation. So especially patients with CVI or again, with a lot of fibrotic tissue where we want to be a little bit more aggressive, then they have that option. Another popular option specifically for upper extremity is the wave. So again, similar to peristaltic where it will inflate, deflate. And what you may notice, you may have some upper extremity patients who have some sensitivity in the hand or the wrist where they don't want to maintain that distal inflation. So it will inflate and deflate 2 chambers at a time. So again, it's still preventing any lymphatic or vascular fluid reflux, but giving them that consistent pressure. So furthermore, if we want to go to the advanced settings, this is where we can get extra customizable. So you see up here, there's the ability to turn the gradient on or off. And I know that different therapists have different opinions about this, so we can maybe open up the floor to questions kind of towards the end. But you can turn the gradient on or off, and even going into the hold time. And so the hold time, so if we take, for example, let's say this is a leg sleeve, a single leg sleeve, the hold time essentially means once the cycle has reached the very top of the garment, so it's completely inflated, it's going to hold that inflation, hold that compression for about 10 seconds, and then it deflates, right? After that deflation, that's where you see the pause time. So the pause time here is set for 10 seconds. So if we wanted to change the hold time or pause time, it's very easy to do that just by simply toggling. Okay, I'm just making this up as we go on that. So one final thing I want to show you is the actual pressure settings. So for some patients who may have extra sensitivity anywhere on their upper or lower extremity, we can literally go chamber by chamber and adjust that. And I've actually seen quite a bit of veterans in the VA hospital who are amputees, for example, that are either above or below knee, but they still have an abdominal component. So we'll actually get them the pantsuit, and I can actually turn off some of those distal chambers so it doesn't inflate at all. It'll just basically focus on the stump and upward, right? That's just one example. Or you may have an upper extremity patient, for example, who may have a very sensitive spot on his or her forearm to where you don't want to apply any compression at all. So again, just that level of customization and a very easy to do application here, okay? So I'm gonna hit okay. And let's just say, for example, we really like this treatment, so you just hit that save icon. And I'm just gonna call this Jake. Jake, this is your custom treatment, hit save. And then when you go to the save treatments here, you can see all of the different save treatments that I've had with this particular device. So then there's Jake right there. And again, I talked about sharing these customizable treatments with your patients. I know not all of you want to give your cell phone numbers to your patients, so you can actually do it via email as well. So if you just hit there, share, you can do via email. And I'm going to share this with you, Jake. Boom. Check your inbox. You just got your new Lympha Press treatment. All right. And just two other minor features here I wanted to share. So again, if we think if it's an upper extremity patient who you want to decongest the trunk area, or again, lower extremity where you want to decongest the trunk, that's where we have pre-therapy, where it will inflate, deflate these chambers first, kind of similar to the MLD principles where you want to work the trunk area first. It'll do that for anywhere from the 5-minute, which is short, or 10-minute long, okay? And then finally, post-therapy, this is where if a patient has a certain area of their extremity, you want to kind of give it that final sweep that you're going to do like you're doing MLD. So let's say, for example, it's their upper thigh that tends to swell a little bit more. You'll just simply highlight that area, and at the end of the treatment, it will isolate that area and just give it one final sweep of compression. So hit OK. Simple as that. And the other thing that's great about the Optimal Plus is I talked about earlier a little bit about compliance, and I'm sure we've all had those patients that said, oh, I've been pumping 3 times a day or 2 times a day, or I pump every week. Well, with every Optimal Plus, when the patient utilizes the free Lympha Press app, there's a great little feature here called usage history. So that pulls you up a quick little report. It tells you the date, the time they pumped, and it tells you what cycle and the pressure. And again, this isn't to get patients in trouble. This is basically so you can collaborate. So if Mrs. Smith says, hey, I've been pumping once a week, or I've been pumping twice a day, it gives you that ability to make adjustments kind of on the fly. So again, it's not to say, hey, you really haven't been pumping as much as you said. It's really for those patients who do want to be compliant, so you can kind of make those adjustments. And any questions before I turn it over to Dr. Chen? And I'm sure at the end, if you're not already familiar with it, we obviously have a couple of demo pumps back there that you can try on and just kind of get a sense of how it feels. Cool? And I know dinner's arriving, so I'm going to get Dr. Chen set up with his laptop, so you guys can pull me aside at the end if you have additional questions. All right.
Is it possible we get a microphone?
Deb, do we get a microphone? Do you guys have a microphone? No microphone?
Do you turn tables in a microphone? No.
Yeah, maybe a styrofoam cup.
That's okay, that's okay. Today is my clinic day, and usually clinic day I talk a lot, so I'm kind of talked out, but...
Where's your HDMI?
Here. Still.
There we go. Okay.
All right, so looks like we're out of focus a little bit. All right, I'm Wei Chen. I'm a plastic surgeon at the main campus. Are we all the Cleveland Clinic therapists or regional therapists in the area? Okay. Well, I really appreciate the opportunity to meet all of you, and yeah, thank you, Cam, and thank you, Lympha Press. I guess I'm supposed to say a thing or two about the pump. So what I can say is I know it's somewhat controversial about the use of the pump, and to be fair, there's no, I mean, I looked at all the evidence out there. It is fair to say that the evidence is not, all the evidence that are out there are not high quality. And some of you have heard me saying that we are in the process of launching our study and we're being stuck at the IRB stage. But I can say, based on our understanding of lymphatic physiology, there's no reason to think that the pump would be harmful. Based on our understanding, we can speculate that the pump should be helpful. However, once our study, this is not a difficult study to do. I mean, we have all the technology to measure lymph flow, so give us some time and we will come out with a definitive answer. And at that time, we can stop debating. In fact, so I'm a professor in plastic surgery. I'm also the co-director for our multidisciplinary lymphedema center at Cleveland Clinic, as well as the chief in super-microsurgery and microsurgery. Another hat that I wear is I serve on the board of directors of LANA. And actually this past weekend, at LANA, we had our research committee meeting. I proposed to the LANA board that we tackle all the controversies among the therapists, such as does blood pressure cuff cause lymphedema, such as does the pump cause fibrosis. Some therapists feel that the pump will actually cause damage, and some feel that the pump is helpful. Well, don't debate with each other. Convince each other with evidence. That's really the key message. So the study that I mentioned, we at Cleveland Clinic, we're going to tackle it regardless of whether LANA gets on board or not. But LANA, the board of directors, we are in general very interested in sorting out all these controversies. We want to put science into what we do and not just anecdotes. All right, so I'll get to my topic. So this is a 1 hour talk. There's no way I'm gonna get through this. So we'll get through as much as I can. If you're interested in this whole talk, please join us in the Power Lymphatics. That's coming up in March, and I'm gonna be the keynote speaker. And actually, I think my talk is 1 hour and 45 minutes. So I'll talk for 1 hour during Power Lymphatics, and we'll have 45 minutes of Q&A. So I invite you to all bring difficult questions if I don't get to answer your difficult questions today. So we're not going to follow all that, so feel free to ask any question you have. So I think I'll talk a little bit about lymphedema diagnosis and a little bit about everything, a little bit about surgical treatment and so on and so forth. We'll see how much time we have, and when you can't stand me talking anymore, then I'll stop. All right, so the diagnosis, this is quite important. Lymphedema should not be a clinical diagnosis, even though that's how it's most frequently diagnosed. If you don't mind, I'm gonna remove my mask and standing pretty far away from you. All right, lymphedema should not be a clinical diagnosis. And for a very obvious reason, there are too many conditions that mimic lymphedema. If you're diagnosing lymphedema with a tape measure, with stemmer sign, you're going to make mistakes. I'm going to make mistakes. I mean, despite how many lymphedema patients I've seen, I'm not even name numbers. I've seen a lot of lymphedema patients. I can't tell you I can reliably diagnose lymphedema with just history and physical exam. Stemmer sign is just your inability to pinch the skin because of elevated soft tissue turgor. It's terribly non-specific. It's also terribly insufficiently sensitive. You all know in the early stage of lymphedema, you can see the patient at a good time or at a bad time. So the stemmer sign could be falsely negative or positive. It doesn't really mean much. Tape measure, we all know it's so bad. I wish that we can stop doing it altogether. It has unacceptably high inter and intra-rater error. You take the tape measure the patient 5 times, you'll get 5 different numbers. And then you can say, okay, so I'll take the average. That's average of 5 wrong measurements. The fact is, anyway, it's a bad test. It really shouldn't be a diagnostic study. This is not even a complete list. This is a list that I put together in 2 minutes. These are some of the conditions you will need to rule out when you're trying to diagnose lymphedema. it's not surprising there's so much lymphedema patient being diagnosed with May-Thurner, because May-Thurner is a much commonly known diagnosis compared to lymphedema, and it's a diagnosis that's familiar to vascular surgeons. So a lymphedema patient going to a vascular surgeon will likely be diagnosed with May-Thurner. This is another one of our studies that is ongoing. It is a retrospective review of how many patients that comes to lymphedema vascular service and plastic surgery service who really had lymphedema but were initially diagnosed with May-Thurner. Even worse, they were stented. So they had a wrong diagnosis, they had the wrong surgery because the surgeons made the wrong diagnosis. And this is all due to us not knowing how to properly diagnose lymphedema, because the patient might have been presented, everybody knows about stemmer sign and circumference measurement. The patient might have presented on a good day and therefore had negative stemmer sign and negative circumference measurement. So, imaging study, this is how we should be confirming the diagnosis. You see the patient, you see a history that is suggestive. Physical exam findings are also suggestive of lymphedema. Now you need to confirm it. And you confirm it with ICG lymphography, or if ICG lymphography is for whatever reason not available to you, get a lymphoscintigraphy, which is much more widely available. But whether it's ICG or lymphoscintigraphy, it needs to be confirmed with an image-based diagnosis. We won't go into the injection pattern. And this is what an ICG lymphography looks like. It's broken down into an immediate scan and a delay scan. In the immediate scan, we look at pump velocity, we look at the pump function, we also look at the distribution of the lymph channels. We know lymphatic anatomy well, so anytime when patient has abnormal anatomy, even if the flow velocity is normal, we know something is off. And then we look at, we need to perform a delay scan. In delay scan, we look for the so-called dermal backflow pattern, and there are several different types. Splash, stardust, diffuse pattern. Depending on the type of dermal backflow pattern and the distribution of the dermal backflow, we know the severity of lymphatic injury. So this is a lymphographic staging system. This is not a clinical staging system. You might have heard of the ISL, International Society of Lymphology staging, MPC staging, and then there's like five different Chang, Chen, and Chang staging. Those are all clinical staging. This is a lympho. For some reason, there are a lot of Asian lymphedema surgeons. But this is lymphographic staging. This is actually much more relevant in the sense that this is reflecting true severity of lymphatic injury. This shows you why you need to do a delay scan. And as I had mentioned to some of you earlier, this is immediately following injection. This patient has left arm lymphedema and healthy right arm. And you can see right after injection, you don't see any dermal backflow pattern. So unfortunately, as of now, not too many institutions know how to properly perform ICG lymphography. So you're in the area, if you need ICG lymphography, we're happy to share how we do our ICG lymphography. If you have access to the machine, we're happy to share how we do it. But if you don't have the machine, send the patient to us. We're happy to reach the diagnosis for you, send the patient back to you. You can see at 2 hours out, we're starting to see dermal backflow. 4 hours, we see even more. 6 hours is when the pattern plateaus. Plateauing meaning that from 6 hours to 12 to 14 hours, it remained relatively unchanged. So this is non-stimulated state, meaning following injection for 6 hours, we're not controlling the patient's activity. They do whatever they want. And it takes 6 hours to plateau. Actually, to be exact, this is from a study, 80+% of the patient plateau. That means about 15–16% of the patient, they haven't plateaued yet, but at least they're almost there. And 6 hours is what makes sense for a busy clinic. That means if I inject the patient first thing in the morning, I do a delay scan by 2–3 o'clock in the afternoon. can't make it any longer because our nurses need to leave by 4 or 5 o'clock. So plateau phase and regression point. So there are all kinds of other stuff. Whether you do circumference measurement, whether displacement or 3D scanning, know that they all fall under the volume-based measurement category. And the best volume-based measurement is 3D scanning, which we are doing. But you need to know that volume-based measurement is limited by all these parameters. They are time-based. They change with time. They're affected by weather, by activity, how much salt they have taken in, whether they're wearing compression garment, the time when they remove the compression garment before you measure them. They might not even put on compression garment because it's so cumbersome in the morning because they know they're coming in to see you, or they might be wearing it up until you're ready to measure them, they take it off. Then that all affects your measurement. The presence or absence of solid disease component or the lymphedema-induced lipodystrophy, that also affects your measurement. So volume-based measurement, if you're going to do it, this is the gold standard, whether you do the German parameter or use the Lymphatech. Not advertising for them, I'm not paid by them. Those are much better than your circumference measurement. But even that is not a good modality for diagnosis. Bioimpedance, I've talked to the company already, I'm not going to name names. They're touting bioimpedance as an early detection tool. It's not. It's not. If you rely on this, I can tell you this has so much false negative. It's unacceptable. It's too high a false negative. So don't use bioimpedance for early don't use it for diagnosis. It definitely doesn't give you early diagnosis. Far from it. And also, there are different types of bioimpedance. There are whole body bioimpedance. There's segmental bioimpedance. If you're going to use it, segmental bioimpedance is superior than whole body. And quantitative bioimpedance, the ones that tells you how much fluid there is in the affected limb, is superior to the manipulated ones that give you a ratio of affected limb to the contralateral healthy limb. So this is an example of quantitative bioimpedance. I can't read the number, but basically this bar right here is normal. And this is right arm, left arm, trunk, right leg, left leg. It tells you how much fluid the patient has. And this is a great tracking modality to track the patient longitudinally over time, but it's not good for diagnosis. And we've done multiple studies looking into this. If you're interested, please look up our study. So BIS, or bioimpedance spectroscopy, doesn't have sufficient sensitivity and specificity to be used as a diagnostic modality. It is, however, valuable in providing longitudinal tracking. So that's what this modality is for. All right, I guess I'll skip this because it will end up being too long. Actually, I'll say a little bit about primary lymphedema. So what do we know about primary lymphedema? I'm sure you've all heard of congenital lymphedema, lymphedema precox, lymphedema tarda, depending on when the patient became symptomatic. What does it mean? So someone has lymphedema congenita versus another patient having lymphedema tarda. What does that mean to you, other than telling you the time of onset? Nothing. Nothing. And as physician, the physician has a bad habit of we like to put our name next to it. Milroy's disease, Major's disease. What does that mean? Doesn't mean anything. Doesn't carry implication in treatment. Doesn't tell you prognosis. It really doesn't mean anything. What it means is it's reflecting our lack of understanding. We don't know anything about, or I should say we didn't know anything about primary lymphedema. What's so special about age 35? Why before 35 we need to have one category, after 35 we need to have a different category? There's nothing special about age 35. I'm going to tell you what matters in primary lymphedema. So we now have sufficient evidence to make this statement, and our study should come out, well, hopefully soon. But we're backing up this statement by more than 600 patients. Primary lymphedema is not a localized disease, meaning your patients show up with a diagnosis of primary lymphedema of the right leg. There's no such a thing as primary lymphedema of the right leg. Primary lymphedema is a global lymphatic hypoplasia, meaning if the patient shows up with primary lymphedema of the right leg, if you look at the left arm, there's issue in the left arm. If you look at the right arm, there's lymphatic insufficiency in the right arm. Look at the right breast, there's also a problem in the right breast. It's not just in the leg, it's everywhere. So there are several implications to this finding. By the way, this is unpublished finding. And, but I think we're ready to share it. This means that the disease severity of primary lymphedema really depends on the severity of hypoplasia or the severity of underdevelopment, assuming healthy being 100%. So primary lymphedema is not one disease entity. You can imagine someone who's 90% developed will behave very differently than someone who's only 10% developed. And will have very different disease course. Will respond very differently to treatment. Someone with only 10% of their lymphatic system developed will be extremely resistant to whatever you do, because there's not a whole lot of pathways for you to push lymphatics. So is that relevant for you to know as a therapist? Definitely. You want to know that before you even start treating the patient. And I know some therapists are resistant to the idea of image-based diagnosis because they feel that it would hurt them in terms of insurance if they can't diagnose the patient with lymphedema before obtaining an imaging study. But this would help you in your treatment of the patient. And also this means that you need to observe the other parts of the body for pathogenesis. Just because the patient is now only symptomatic in the right leg doesn't mean that this patient won't develop left leg lymphedema next year, or 5 years down the road, or 10 years down the road. This also means that when we treat the patient as a surgeon, we need to try to stay away from the transfer-based procedure. Transfer-based procedure, what are transfer-based procedures? Lymph node transfer, lymph vessel transfer, any of the procedure that involves taking something, robbing Peter to pay Paul, because we can set off problem in another part of the body. This also means that this patient is much more likely to develop lymphedema with iatrogenic or traumatic injury, such as sentinel lymph node dissection. So this is why some patients develop problem, others don't. Because many of the patients, by the way, I can tell you this is not rare. We don't know, however, the incidence of primary lymphatic insufficiency or asymptomatic lymphedema, whatever you want to call it. The incidence is unknown. I can tell you it's not rare. I see them. My lymphedema clinic is every Monday and Friday, and I see them every time when I have clinic. Today I saw a bunch. All right, so this is what they look like on ICG study. Here are 3 patients with primary lymphedema and take a guess which one has the most severe hypoplasia. All of them have left leg affected. This patient, you see dermal backflow in leg and thigh. This patient, you see some linear pattern, a little bit of dermal backflow here and then nothing. This patient, you see dermal backflow start as pattern here and nothing in the thigh. The one in the middle has the most severe hypoplasia. So this is the most difficult to treat. Actually, if there's another surgeon that I can bounce this patient to, I would. This would be very difficult to treat. So before you even touch the patient, you need to set expectation of what's ahead. This is going to be very difficult because the patient really doesn't have a lot of lymphatic tissue for you to work with. So the first patient with dermal backflow all over, this patient will behave very similarly to those with acquired lymphedema and will be more responsive to treatment, both surgical and lymphedema therapy. whereas this one will be challenging to treat. Furthermore, this patient will most likely experience a rapidly deteriorating course. And so those patients with primary lymphedema that are symptomatic at birth, these tiny babies, if they're already symptomatic, that tells you they have fairly significant hyperplasia because they have so limited lymphatic function that they are already symptomatic the moment they're born. That's a poor prognostic sign. So for these babies, actually the treatment should be, I strongly recommend surgical intervention for young patients. And that's a separate discussion, but the rationale is, first of all, they have significant severe hyperplasia. Second, they have long life ahead of them. There's so much time for them to worsen compared to someone in their 60s or 70s. All right, actually I'm gonna skip this, otherwise my talk is too long. Surgery or therapy. So I don't think surgery is second-line treatment. I guess so frequently you're hearing that lymphedema therapy should be the first-line treatment, surgery should be second-line. I strongly disagree, and I have plenty of evidence to tell you why that should not be the case. What I consider surgery and therapy is these are two equally effective treatment modalities. They are not the same. They have different advantages and disadvantages. So both treatments, in my opinion, should be discussed equally with the patient. Once you have a confirmed diagnosis of lymphedema, you talk to the patient, look, we have these two very different treatments. They each have their pros and cons, and they achieve different things. And usually the advantage of one is the disadvantage of the other. For example, the one benefit of CGT is that it's non-invasive. Surgery is invasive. And when therapy fails, patients are usually not worse off. Surgery is the opposite. Surgery can have complications, patient can be worse off. So these all need to be discussed, and patient may say, okay, now I understand both. I want therapy or I want surgery. Both should be equally discussed, not one and two. That's my opinion. All right. So these are all the surgeries that are currently available. At Cleveland Clinic, we offer the full spectrum of the surgery. And there are certainly surgeons out there who takes a hammer and nail approach. They believe one procedure is the best, and they treat everybody who walk through the door with that one single procedure. I can explain why that's not a very good approach, but I think anyone can understand this. One size does not fit all. So you probably heard super-microsurgery all the time. What is super-microsurgery? This will give you a scale. So I'm showing the median vessel size work done by surgeons. So the full name of super-microsurgery is super-micro-neurovascular surgery, meaning we work on tiny nerves, really, really tiny nerves and blood vessels. So this is a vascular surgeon, and femoral artery is the median vessel size that they work on, which is 8 millimeters. This is cardiac surgeon, left anterior descending coronary artery, 3.7 millimeters. That's the median vessel size they work on. This is what we as a micro-neurovascular surgeon work on. The IEA, that's the D-flap, blood vessel use in D-flap for breast reconstruction. That's usually 2 millimeters. And in comparison, in lymphaticovenular anastomosis, super-microsurgery, that's what it looks like, 0.1 millimeters. So, that's us, and that's cardiac surgery. So that gives you scale. All right, so this is the, I guess I won't go into this, but this just means, this is my algorithm. It means that at all stages of disease severity and lymphedema, there is a surgical treatment for the patient. So essentially all patients are surgical candidate. It's not a matter of how severe their diseases are, it's whether they're interested in surgical treatment. With some exception, of course, if they are not a good surgical candidate, bad heart, bad lung. If you operate, they probably would die. Or if they have BMI 50, of course, I mean, they're not a good surgical candidate. But disease severity doesn't contraindicate them. Lympha is the preventive LVA preventing lymphedema, and it's best performed before lymphedema starts. And that falls right there, and it's offered to patient with stage 0 disease. That's when the patient has lymphatic injury but no symptoms yet. And this is a very easy for the patient. Procedure takes about an hour to an hour and a half. It's performed as outpatient, and it can be performed under local anesthesia. And our success rate to date, we only have 49 cases, and that's because I haven't built up my local referrals. As of now, even though I'm very busy, but 90% of my patients are from out of state, I need to work harder with our local referral. But our success rate is 100%. No one has developed lymphedema, and I personally don't believe in any surgery having a 100% success rate. It's just a matter of us doing more and having longer follow-up. But certainly, as of now, our outcome is highly favorable. If you're interested, please look up our study. And that's what it looks like. 1 or 2 cut at the elbow for the upper extremity, 1 or 2 cut at the knee, and lymphedema prevented. That's what it looks like. That's our mapping. We mapped out the lymph vessel, and then the dotted lines are the veins. We mapped out the vein, and that's the preventive LVA. Therapeutic LVA, it's similar, it's just more cuts and takes a little bit longer. Again, the solid lines are lymph channels, dotted lines are veins. The different color represent different lymphosomes. Lymphosomes are lymph drainage territories. So when you inject at one spot in the arm or in the leg, only the lymph channels draining that spot will light up. The remaining lymph channels won't light up because only the lymphosomes in draining that spot will light up. This won't be of interest to you, just of interest to lymphatic super-microsurgeons. There's a lot to be said in how to get them together, although most of the American super-microsurgeons are sticking with end-to-end because that's the lowest hanging fruit. It's the easiest to do. By the way, most of the LVA falls in the range of 0.1 to 0.6 millimeters, and the sutures that we use are 12-0 and 11-0. In comparison, for heart surgery, it's 7-0 and 8-0. The more O, the tinier they are. By the way, hair is about 8-0 to 9-0. Not even 9-0. Hair is about 7-0 and 8-0. So the sutures we use are so much smaller than hair. If you lose the suture, you don't look for it because you won't find it. This is a demonstration of LVA. You will see a 0.3 millimeter lymph vessel that's covered by this tiny piece of sponge connected end to side to a 0.9 millimeter vein. We're under 40 times MAC right here. You'll see the square. This is a microsurgery background, the yellow stuff. There are squares on this yellow background. Each square is a millimeter. So that gives you scale. And this forceps right here is a titanium super-microsurgery forceps. The tip of that forceps is 50 micron, or 0.05 0.05 millimeter, 50 micron. So that would also give you scale. Okay. And it's not robot doing the surgery. People always ask. That's my fingertip. So that's a 12-0 suture, and that's a 50 micron needle. So in this video, we didn't see the patient's hair. If we see their hair on the arm, the hair is thicker than the needle. So that's the first stitch, and so that's the 3 o'clock stitch, and the next is the 12 o'clock stitch. tip of that needle holder is 0.1 millimeter. So for trained super-microsurgeon, actually anything larger than 0.5 is very straightforward, technically straightforward. Smaller than 0.5, then it gets substantially more technically challenging. And this is a 0.3 to a 0.9, so it's relatively straightforward. And that's an airborne suture technique. I did it too quickly anyway. So yeah, so that's that. This is what it looks like. It's fairly minimally invasive and a bunch of tiny cuts. Usually each one is less than 1/4 of an inch, half an inch. And a patient usually wake up with no pain. They would say, "Did you do anything?" And I said, "Yeah, we did a lot." And LVA works quickly. Most patients usually feel a difference in a matter of days. If 1 month out they feel nothing, I start to think the surgery failed. This is, for some reason, contrary to what most other surgeons are saying. Most other surgeons would say, don't expect any improvement until 1 year out. That's not my experience. If the patient experienced improvement 1 year later, I'm not sure if the improvement is because of my surgery. Maybe it's something else. We do about 2 to 3 of these. Tomorrow I have one, Wednesday I have one, Thursday I have another one. Well, in the Cleveland Clinic system, if you're interested in observing surgery, actually, even if you're from outside, we welcome you to come. If you're interested in observing, if you're from outside, maybe there's a bit more paperwork, but if you're interested, you're welcome to come. All right, a working LVA would look like this. So that's what lymph flow looks like. So this is a double LVA, 2 lymph vessels connecting to a single vein, one end to end, one end to side. You can see the phasic flow of lymph vessel. It's not a continuous flow. There's even a little bit of retrograde flow. Here's another wave coming in. So even though both lymph vessels were flowing, but you're only seeing one because only one was, we injected lymphozurin in this particular lymph vessel's lymphosome, and therefore this one didn't stain blue. All right, lymph vessel transplant. I think I'll skip this one, or there's too much. My talk would be too long. Your food will get cold. So that's the reason why I prefer lymph vessel transplant. The lymph node transplant, even though it works great, it doesn't look very well. And so this is our own technique. We developed these lymph vessel transfer technique. Now, lymph vessel transfer is super-microsurgery technique, and it allows us to preserve the lymph nodes. We're not touching the lymph nodes. And this is a patient prior to surgery, 2 weeks out. You can see the reduction already. I've already said I don't like the volume-based measurement, but these pictures were taken from, the patient was bragging about her outcome on social media, and I took the picture from her social media. And these were our own pictures. It works great. It's highly effective. This patient, you can barely see the lymph vessel transfer. It's down here. And if you're interested, all of these are from studies. So I try to stick with evidence-based practice as much as I can. So most of what I'm telling you are based on studies, and you're welcome to look up our studies. Liposuction. A lot of people call it SAPL. I don't know why they call it SAPL, suction-assisted protein lipectomy. I don't know where the term protein comes from. It's liposuction. So what's different about our liposuction is we trim the skin off afterward. And we call it the flying squirrel technique. This was also published. And this is why we need to remove the skin after liposuction. This is how much skin there is after liposuction is done. You can see That looks like the wings of a flying squirrel, and therefore flying squirrel technique. So this is after liposuction. That's liposuction incisions, and that's how much skin we will cut out. That's after the skin removed. That's what the patient will look like before surgery, after surgery. And even a patient like this can still be treated. This patient has early elephantiasis, and after liposuction, she looks like that. Another patient with left-leg solid predominant lymphedema, and after liposuction, she looks like that. She has a long scar on the inside part of the leg, but since we placed the scar on the medial side of the leg, it's fairly nicely concealed. This is what can be achieved on the table before surgery, right after at the completion of surgery. You can turn a bulky arm into a skinny arm. What this means for the therapist is no amount of compression and MLD will get rid of lipodystrophy. And once the patient has this much lipodystrophy, she will be resistant to compression. She will be resistant to your compression. After this, now this patient most likely will be able to downgrade her compression class, because now your compression is directly on the fluid compartment and not on the lipodystrophy and fibrosis. Someone like this can develop and make a bulky arm into a skinny arm. This does create some problems. Most of our patients are not very fit. This means that after surgery, their lymphedema arm will become smaller than their healthy arm. So we need to talk to the patient ahead of time. Most of them will be happy to accept this result. They usually will say, I'll just pay, self-pay to get an arm lift to match. Hyperrecon, that means liposuction first and then performing lymph vessel transfer, or LVA, afterward. And the same patient I just showed you before liposuction, after liposuction, and we were getting ready to transfer lymph vessel to this area after lymph vessel transfer. This is what she looked like 2 days out. You can see the leg was completely decompressed compared to on the table 2 days out from surgery. Look at how wrinkled her leg was. And this is what she looked like prior to liposuction. Okay, I think I will stop here. It's too much, it's too long. Outcome. This is an ongoing retrospective review that we are hopefully going to put out maybe by the end of the year, but our 4-year outcomes are excellent. If you can look at our outcomes, subjective improvement, mid-90s, decrease in lymph volume, 78%. That's because, by the way, I just said volume is a poor measurement of outcome, because patient with solid predominant disease, you treat the patient with a reconstructive procedure, don't expect the limb to get smaller. Patient has lipodystrophy and I treat the patient with LVA, the leg is not going to get substantially smaller. That doesn't mean there's no improvement. Patient will tell you, my leg feels so much lighter, I have improved range of motion, I have improved exercise tolerance, my leg just feels lighter. I mean, these are all important improvement. Decrease in rate of infection, improvement in lymphedema quality of life, or lymphedema Q, or patient, this is worth mentioning. Patient who stop having any symptoms, or stop the need for further compression. I'm not going to use the C word because a lot of people feel strongly about it. 18%. So small percentage of patients can stop experiencing lymphedema symptoms and they stop compression. We can call it profound improvement, aggressive improvement, whatever you want to call it. 18% of the patient. And for these patients, they usually no longer remember they have lymphedema, and we lose these patients usually about 3-4 years out following surgery, because lymphedema is no longer a part of their life. They don't care about us anymore. They don't want to come back. Patients who are happy and feeling hopeful about the future. Now, this is very important. So many patients, when they came to us, they are upset, they are disappointed, they're frustrated, and they feel hopeless. They feel that doctors don't know anything. Therapists are a little bit better, but in general, we can't help them. We don't understand, we don't know what we're doing. So this is what I heard from our patient a lot. Their confidence for modern medicine has been renewed, rekindled. They feel hopeful. This is why this year we decided to come out and talk about this 18%. With actually seeing a patient with this profound improvement cure. The first case of cure that I saw was in 2012. Myself and several other surgeons from around the world, we don't talk about it just because as surgeons, we always believe in under-promise, over-deliver. And especially, we're not sure how we cure these patients. The same procedure, but most of the patients were not cured, but some got cured. So we kept our mouth shut, but I feel that as physicians, we also are bound to, we need to report to our patient as is. We shouldn't be hiding from our patient. If we are curing, why are we hiding? Not to mention, if you tell the patient that we may not cure you, but we have cured, that has such a positive impact. Just to let the patient know that there is hope. I think it's definitely worthwhile. Here's a patient telling me she was cured. All right. Anyway, I don't know what's wrong with the audio. So you can barely see her incision. She's 1 year out from LVA. She stopped wearing compression 6 months out, despite that's against our advice. But patient knew if they're ready to take off compression. This patient, this is important. If you have arm lymphedema patient who complain of numbness, tingling, clumsiness, those are nerve compression symptoms. Well, if it's radial nerve distribution, that's radial nerve compression, median nerve distribution, median nerve compression, clumsiness, that's ulnar nerve compression. Don't send the patient to a hand surgeon. A hand surgeon, I made the mistake myself, plastic surgeons are hand surgeons. I made the mistake early in my career to do nerve release. Wrong treatment. The treatment is to treat lymphedema. In this case, lymphedema caused their nerve compression. If you treat lymphedema, their nerve compression goes away. So, yeah, you didn't hear her, but you need to take my word for it. She was saying she was having a lot of clumsiness, numbness, and swelling, and after LVA all went away, she stopped wearing compression garment 6 months out, and 1 year out, she still has no issue. So this is what I said, we use ICG to track patient progress. Here's prior to surgery, after surgery 2 years out. You can see the improvement in Stardust pattern. Okay, that's it.